Let's look at the proton pump inhibitors. The first one of the older ones, is omeprazole, and there are very many Me Too drugs, or very similar drugs to omeprazole, that are on the market at the moment. These drugs, such as omeprazole, block irreversibly the hydrogen potassium proton pump, and so they reduce gastric acid secretion, and they're very effective. Often they come in coated tablets that protects them. The other group of drugs that are used to suppress acid secretion, as we said before, histamine H2 receptor antagonists, such as ranitidine, or some people may have taken this drug as an over-the-counter medication as Zantac, but it's ranitidine, a histamine H2 receptor antagonist. We talked about the prostaglandin E2 analog, misoprostol. Now, the reason you would take misoprostol as well as the non-steroidal anti-inflammatory drugs is because the non-steroidal anti-inflammatories block all prostaglandin production, and usually the prostaglandin F series are very inflammatory, whereas if you take prostaglandin E2, you'll replace the suppression of gastric acid secretion, but you'll still get suppression of other prostaglandins involved in inflammation. So it's a two-drug type of pharmacology to overcome an inflammatory condition while suppressing gastric acid secretion. Omeprazole and similar drugs, proton pump inhibitors, ranitidine, histamine H2 receptor antagonist. Well, now we come to the causes of gastric ulcers and the role of Helicobacter pylori infection. Helicobacter pylori is a gram-negative anaerobic bacteria that invades the mucus layer. Of course, as you're probably aware, no one thought that a bacteria could live in the acid environment of the stomach, and Barry Marshall in Western Australia won the Nobel Prize for Medicine for his discovery of the role of Helicobacter pylori in gastric ulcers, and obviously this led to the eradication of many gastric ulcers and improved gastrointestinal quality of life in terms of gastrointestinal function for millions of people, a real contribution. Now, Helicobacter pylori, shown in the picture here, this spiral anaerobe, is endemic in the population, and in many individuals it doesn't have any symptoms for years, but then with age, for some unknown reason, the symptoms appear. That seems to be a genetic susceptibility. Some people seem to be able to have the bacteria without very many adverse effects, whereas some people develop ulcers. And all this is an area where there's a little bit of unknown causation, what triggers the appearance of the symptoms. Interestingly, Helicobacter pylori is a relatively fragile bacteria, and although it's infectious, the transmission's not clear how it gets in. There is a hygiene component. There's a higher incidence in developing countries. It's thought sometimes that it's transmitted to infants, and it's harboured for many years under the mucus layer where it's protected, until for some unknown reason it creates difficulties. If there are ulcers formed, then the risk of gastric cancer is much greater. and the contribution of the bacteria or the ulcer, whether it's the damage and the ulcer that causes a problem, or whether it's the presence of the bacteria alone is also a risk, is not really clear. Maybe you need both. Maybe the underlying presence of the bacteria is a serious problem, regardless of whether there are ulcer symptoms. Now, as we said, Helicobacter pylori is responsible for many ulcers, and it's responsible for most of the ulcer disease that's not caused by people taking non-steroidal anti-inflammatory drugs. Not only is it fragile, but and protected when it's under the mucus layer, but the bacteria secretes bicarbonate ions by an enzyme called urase that produces bicarbonate, which increases the pH or reduces the acidity of the local area of the bacteria, which then partially protects the bacteria from the acid environment as well. This causes trouble because the urase activity increases the pH, releases ammonia and bicarbonate, and increases the pH. That stimulates gastrin secretion, which acts to further increase gastric acid secretion. Also, the bacteria causes inflammation, and the inflammatory meters tend to reduce the production of mucus. So you get increased gastrin secretion, not just in the local area where the increased pH is, where the bacteria is, but throughout the stomach. This increases gastric acid secretion, and that contributes to increased risk of ulcers. The second part of the mechanism, the inflammation in the mucus layer by cytokines and T cell infiltration leads to suppression of the mucus secretion as well. So there's several pathways where the bacteria contribute to ulcer formation. And so if ulcers are present, they can a sample can be taken either with a scope put down into the stomach in a gastroscopic procedure, but also there are blood tests, and in addition there is a breath test in which relies on the particular urase activity of the bacteria to release compounds that are detected in a breath test. So once there's disease and the bacteria is detected, it needs to be eradicated. Now, usually this involves a combination treatment approach. Previously, with one therapy, you might get only a proportion of people treated, but cured, or eradication of the bacteria is not always complete. And so now various combinations of antibiotics, proton pump inhibitors, and bismuth are used to effectively eradicate the bacteria. A typical triple therapy involve a proton pump inhibitor to heal the ulcer, the erythromycin type drug, clarithromycin, and amoxicillin are used in the first line triple therapy. Another combination, depending on the sensitivity of the bacteria to various drugs, clarithromycin can be used with metronidazole. Metronidazole is an anti-protozoal drug, a drug that was developed to treat protozoal infections, amoeboid type infections from eukaryotic cells that cause amoebic dysentery and whatnot. And this metronidazole also targets or anaerobic energy producing mechanisms both in amoeba and in anaerobic bacteria, so that's why it's included in this treatment. There are some other possible treatment approaches as well, but this amoxicillin, a penicillin, clarithromycin and a proton pump inhibitor is the typical first-line treatment and usually works in 90% of patients. So the rationale is eradication of Helicobacter pylori with antibiotics, reduce gastric acid secretion with proton pump inhibitors usually to heal the ulcer, and some other types of therapy, increased protection with a compound called bismuth, which actually is toxic to Helicobacter pylori and protects the ulcer by forming a protective layer. Can also be used in cases where there is a problem eradicating Helicobacter pylori. One of the problems here is that Helicobacter pylori is being treated in many patients now, and so these antibiotics are commonly used, and there is an incidence of resistant Helicobacter pylori infection to some of the antibiotics. So sometimes the first-line therapy is not effective, and then some other approaches need to be used to get rid of resistant bacteria if the patient's unfortunate enough to have got a bacteria that either was resistant or has obtained antibiotic resistance